and welcome everyone to this Thrombosis UK session, where we will aim to give an update on thromboprophylaxis and COVID. I'm Susie Shapiro, I'm a haematology consultant in Oxford, and it's my pleasure to be chair of this session. We have two great speakers to discuss our evolving knowledge around thrombosis and COVID, and they'll each give a presentation, and then we plan to do a discussion. So please do submit any questions using the Q&A function, and I'll do my best to build them into the panel discussion to make sure we get the best out of our two experts. The webinar will be recorded and be made available by tomorrow on the Thrombosis UK website. So if you do get called away, then it will still be there. So our first speaker barely needs an introduction, as she's likely to be a familiar figure to all of you. Professor Beverley Hunt is a national and international expert in thrombosis and acquired bleeding disorders. Beverley has sat on multiple national and international guideline writing groups, including NICE, and runs an active research group. She is the founder and medical director of Thrombosis UK and chair of the steering committee of World Thrombosis Day. So Beverley is going to discuss the natural history of COVID and some of the key new knowledge that has been acquired since the start of the pandemic. Over to you, Beverley.
Well, thank you very much, Susie, and thank you so much for chairing this session. It's also great to be with you and Dan again, because I think we're a good team. So I'm really preparing the way for Dan. I'm just going to give a background of COVID for those who might not be entirely familiar with it, which seems probably a little bit surprising, and then a few nuances of COVID that is getting to be so interesting. So this is my plan. I'm just going to talk briefly about VTE risk, immunothrombosis, and also why Lord Voldemort is included in this presentation, just to keep it light. So COVID enters the body through the ACE2 receptor, which is expressed on nasal epithelium and also on some of the pneumocytes in the lung. It's also present on endothelium, adipocytes, duodenum, small bowel, and also the testes. And I think that this is a real growth area, looking at the expression of the ACE2 receptor. In the last few months, people have shown that the ACE2 receptor is much less prevalent in children, and it increases with age. So it may be yet another factor as to why increasing age is a risk factor for getting COVID pneumonia. So as we look at people who have COVID, thankfully, most people have either asymptomatic or minor infections, maybe some anosmia, maybe headache and myalgia being newly described as being a major feature of mild infection, but then they get over it. And what we're seeing in hospital is those that develop COVID pneumonia, and they develop hypoxia, and there's invasion of the lung with a massive inflammatory response, cytokine storm, and there's activation of lymphocytes and macrophages and complement and platelets. Anything that would operate in an inflammatory environment is activated. And a consequence of that is that the inflammatory state causes cytokines to be produced that lead to a profound prothrombotic state. And there's growing interest in the people who are at risk of COVID pneumonia. So we are talking about being male, obese, advancing age, and underlying cardiovascular disease and diabetes, all of them associated with slightly stickier blood. I do this every time I do this talk, and I think it's just reminding people of the basics, because if you know the basics, then COVID sort of makes sense. So that the coagulation system is an effector system of the immune response. So it evolved when primitive organisms needed to wall off invading bacteria, and of course you wall off with fibrin. So if you activate the immune response, you are activating coagulation. And that if you've got profound inflammation, as you do, I used to run the Bechet's and the vasculitis clinics at my hospital for many years, you get microvascular thrombosis where you've got a lot of inflammation. So you can give them anticoagulation to treat that, but actually you're not treating it. You need to give them some form of immunosuppressive treatment, such as prednisolone or dexamethasone, to reduce the inflammatory response so you don't get so much microvascular thrombosis. And lastly, in hospital, we have hypoxic patients, and hypoxia is a stimulator of the prothrombotic state. So the hypoxia-inducible transcription factors will bind to the promoter area of several genes, and that includes tissue factor and PI1, and those genes will upregulate and enhance that prothrombotic state. So one of the features of looking at patients who have COVID, who are in critical care, is that they tend to be obese. And looking at them overall, we know from the INAC report that 75% of them are overweight. And when we look at how adipocytes behave when people become overweight, they become larger and they change the cytokines that they normally produce. So everyone seemed to think that adipocytes were very inert, but no, far from it. They're producing a range of cytokines, and they will switch to a pro-inflammatory set of cytokines and will produce more coagulation factors because they are producing interleukin-6, which is telling the liver to upregulate production of coagulation proteins. And the other thing that they will do is produce PI1. And the other thing about the adipocytes is they've got ACE2 receptor on them, so COVID can enter them, and one wonders whether the COVID alters the adipocyte function. We don't know that yet from any experimental work, but I would suspect it does. So we've got a COVID pathway. So patients get the infection, and then 5% of them 5 to 10 days later may be hospitalized with COVID pneumonia. And at that point, they'll have increased risk of hospital-associated VTE for up to 90 days post-discharge. And we're seeing late sequelae, aren't we? So we've got long COVID, which sounds a little bit like post-viral fatigue, but not clear that it is. And then we've got things like COVID fingers and toes, which can occur late. What I have seen in the last few months is patients who are my patients, and they've had VTE, and they have chosen to stay at home despite having pneumonia. And if we remember at the beginning of the pandemic, you were told to stay at home, not to visit the GP, not to go to the hospital. So misguided, or for whatever reason they didn't want to go to hospital, they stayed at home and clearly had really bad COVID pneumonia along with diarrhea and got very dehydrated, and several of them have had clot, but it's not entirely clear what the risk there is. So this is from the first wave. This is our admission criteria, Guy's and St Thomas's, traffic lights. The more hypoxic you are, the more you approach critical care and the need for ventilation. If you're only mildly hypoxic, you end up on the wards with oxygen delivered in various ways. And a little thing that's different this time round is that we are now offering similar care in the community, and I'm going to talk about that at the end. So just to say that if we have people with acute respiratory distress syndrome, we expect them to have areas within the lung where they get microvascular thrombosis. And we've sort of forgotten that, and now we've remembered it. And we call this immunothrombosis. And when we look at the histopathology of all of the papers where patients had COVID and died of COVID, we see immunothrombosis. In some of them, we also see disseminated thrombosis, and it's not clear whether that was a direct result of COVID or due to the fact that they had multi-organ failure at the end and developed a disseminated intravascular coagulation, as patients do when they are dying with multi-organ failure and they're very hypoxic. So these are the type of prothrombotic patients that we are getting. So this is our first 66 patients on critical care with COVID-19, looking at their inflammatory markers. And so we've got fabulously raised fibrinogen levels here in the first on the left. We compared those who'd already had venous thromboembolism with those that hadn't, and they tend to have higher D-dimers if they had a VTE, but there's great crossover, so you can't use D-dimers to actually say someone has had a thrombotic event. So we've got Klaus fibrinogen, normally up to 4, median was 7 or 8, and then that incredible increase in D-dimers. That scale there is logarithmic, and it's going way up 100 times normal. And then we've got increased precalcitonin, ferritin, and CRP, all inflammatory markers, and all moving together. And just to push it home, and I think this is the last time I'm going to do this slide, it is to say, the Chinese said this is DIC, and we've been working backwards since those early reports. This is not DIC. We've got normal or high platelet counts, we've got high fibrinogens, we tend to have normal PT and APTT. This is not DIC. We only see DIC in those who are dying. So I'm going to leave everything really about VTE and immunothrombosis to Dan, just to remind you that we have got the perfect storm with Virchow's triad in COVID in the very sick ones with this really sticky blood, got COVID in the endothelium, and we have got reduced mobility. So ticking off all 3 parts of Virchow's triad, and we also have this immunothrombosis as a consequence of the inflammation. And looking at the mechanisms in immunothrombosis, we've got tissue factor probably switched on, we've got netosis, we've got complement, we've got activation of platelets. You have to say, well, why isn't it happening more frequently? Because we really have switched on all the mechanisms of coagulation. So at this point, I was just going to stop and have another look at the D-dimers and remind you that raised D-dimers are actually a marker of acute respiratory distress syndrome. And this is from Wuhan and their data where they looked at the D-dimers and the patients who had COVID and compared them with the D-dimer levels of the patients the year before who also had viral pneumonia but didn't have COVID. Right at the bottom, and you can see they're very similar indeed. And the question really is COVID coagulopathy and thrombosis worse than other viral pneumonias? Is it absolutely unique? And I mean, just to remind you that about D-dimers, yes, they are a product of activation of coagulation. So when you generate a clot and you generate thrombin, some will ask the endothelium to produce more tissue plasminogen activator, but we also have pneumocytes within the lung generating urokinase, which can also activate plasminogen to plasmin. And we need that urokinase in the lung because the hallmark of ARDS is extravascular fibrin deposition. And that needs to be removed for the lung to heal. And the data suggests that looking at SARS in a mouse model, the more SARS injected, the greater the amount of urokinase that's produced. And we've also got a lot of macrophages in the lungs, and they too can generate plasmin through metalloproteases and also through their lysozymes. They can capture molecules of fibrin pull it in, digest it with cathepsin, and then throw out D-dimers. So that question of, is COVID so unique, or is it just very similar to other viral pneumonias? We're asking at the moment. This is data that's been submitted to publication from our ECMO unit. So we have looked at all the viral influenzas we have had that required ECMO and compared them with the COVID patients that required ECMO. And when we look at everyone gets a CTPA before they start ECMO, and when we look at the rates of changes on CTPA, they are greater with COVID, significantly greater. And then we look specifically at immunothrombosis, by which we read subsegmental and segmental changes on CTPA to reflect immunothrombosis. They were greater. But when we come down and we look at bleeding, there was no difference. And when we look at the rates of DVT, everyone gets ultrasound after decannulation. We had higher rates of DVT. So this study does suggest that what's happening in COVID is an extreme of what happens normally in viral pneumonias. So where are we? Well, we've got more questions than answers still. So I still think we need more data on the rates of thrombosis with COVID, although I've shown you some data that suggests the rates are higher. We need a little bit more work doing so we can separate out what is immunothrombosis and what's PE, and then the many questions we have about thromboprophylaxis. So in the UK, we are using weight-adjusted thromboprophylaxis. That has never been trialed. All the trials looked at standard thromboprophylaxis. And in some of the patients, we're giving intermediate dose thromboprophylaxis. So we definitely need trials. Should we use intermittent pneumatic compression? Should we be using extended thromboprophylaxis? And what do we do about immunothrombosis? So I think that the recovery trial findings that if you use dexamethasone, it reduces mortality in the critically ill patient with COVID by about a third, suggest it's reducing inflammation. And I would suggest that maybe we're going to find there's less immunothrombosis on dexamethasone, and it's something the recovery team, I think, are looking at. And then lastly, we've got guidance out there. We've got ISTH guidance, and we've got ACCP guidance, but it's all guidance. That means it's based on expert opinion, and we really do need the results of clinical trials. So in the UK, we can only really do research through these two platforms, Recovery for the ward patients and REMAP-CAP for the critically ill patients. And we now have an anticoagulation arm on REMAP-CAP. We've enrolled about 170 patients so far, and we're saying, can we compare standard thromboprophylaxis with full dose thromboprophylaxis? We just had yesterday also approval for an antiplatelet arm, which we hope to launch in about a week, and that will compare no antiplatelet agent with aspirin or clopidogrel. So we in the UK are really entering phase 2, or is it a rise of the phase 1 that never went away? I don't know, and I don't think anyone can answer that, but we definitely have got more patients. So we now have got nice cards in our hospital to say this is how these patients should be managed, because we really do understand care so much better. So when these patients are admitted, they need IV fluids, and when we started out they had fluid restriction and it led to renal problems. So now we're giving fluids. They need dexamethasone to reduce their risk of death due to inflammation and COVID pneumonia. And also you can see on the 5 arms of this anticoagulation, it's all agreed that it's really important that everybody gets thromboprophylaxis. And then the last thing is oxygen. So that card you will see at the top, it's for the home team. So we have a hospital at home team, and we can deliver care at home right up to the need for actually giving them ventilation. And I know that there are GP hubs as well. I know Dan's probably going to talk about what's happening in Salford, which is a slightly different way. So we're moving forward to actually treating some of these patients at home. So I've nearly come to the end. Just to remind you all, it is World Thrombosis Day tomorrow. And I think that COVID has been a terrible pandemic, but it has highlighted the need for healthcare professionals to be aware of hospital-associated VTE. And we are doing as much as we can to use COVID as a stepping stone to talk about thrombosis in other patients in hospital as well. So back to Ralph Fiennes, and just say that he is currently in a play at the Bridge Theatre in London. It's all very socially distanced. If you go there, 2 seats together and you're miles away from anyone else. And it's written by David Hare, who's a well-known playwright, and he actually had COVID himself. And whilst he had COVID, he heard me on BBC Radio 4 talking about the clots in COVID and sticky blood, and also that the disease was medieval. And he included some of my words in the play, and also Ralph Fiennes in the play talks about what a DVT is and what a pulmonary embolism is, which is really fantastic awareness about venous thromboembolism. So thanks very much for listening. Back to Susie.
Thank you, Beverley. That was great, and great to see that thrombosis is it has an increased platform through this and through other work that you have been doing as well. That was a really clear introduction to COVID and the pathophysiology, especially immunothrombosis. And so now it's your turn, Dan. So Dan is going to focus now on a bit more information on what we know about thrombosis and COVID, including how that's changed over the course of the pandemic, and then focus on thromboprophylaxis. Dan is a consultant intensivist and emergency physician at Salford Royal NHS Foundation Trust, where he chairs the thrombosis committee, and he's led the service towards recognition as a VTE exemplar centre. Dan's actively involved in research within emergency medicine and thrombosis. And Dan, having had a sneak preview of your slides, I'm really looking forward to your talk, so fire away.
Thanks very much, Susie. Welcome everyone, and thanks to Thrombosis UK for inviting me to speak again as part of this awesome trio. I feel obliged to ask if you can see my slides and to check that I'm not muted. Susie as chairs, everything thumbs up? Okay, good. So I shall press on, and I'm sure Susie will correct me if anything goes awry. So at the bottom of my screen, I've just popped my Twitter handle on there, and I've also linked to St Emmeline's blog, which is a free open access medical education platform that I write for. I have written an accompanying short article that's on the blog there, which accompanies this talk and has all of the references embedded as hyperlinks. So feel free to pop there afterwards and have a look if you want to follow up on any of the literature. And I've done that to try and keep my slides as free and easy as possible. So should we press on? Thrombosis and COVID-19, would you like to know more? Of course you would, because we would all like to know more, wouldn't we, about this disease, which has been responsible for over 1 million deaths worldwide to date, and continues to cause us challenging questions and problems regarding venous thromboembolic disease. But when we want to know more about something, it's important to caveat that, isn't it, with how do we want to know more and how do we want to pursue the literature so that we can provide the best care for our patients. And there's two cautions, I suppose, about seeking extra information in COVID-19. And one of those is that there's the potential for us to ask these questions into our own echo chamber. and only hear back from people who are interested in the same condition as us or have particularly raised awareness. And of course, we need to look at the broader literature and use all information sources that we can. I don't know if any of you have seen The Social Dilemma, but I watched that on Netflix last week, and it gives a good insight into the idea of how social media platforms and internet-based search engines can subtly manipulate data in order to feed you a certain type of information. And we need to be conscious about that with medical conundrums like thrombosis and COVID-19. I'm sure if any of you look at your PubMed feed around the similar articles and cited articles, it'll probably be full of thrombosis stuff. And we have to go abroad from what we would usually look at if we want to capture the full data that's out there. The other caution that I would offer is around the quality of the evidence we're looking at and how we hold that to account. I think it's reasonable to say that the bar for peer review and critical appraisal was probably lowered a little bit in the early stages of the pandemic because we were so desperate for information and experiential learning that we saw lots of publications of retrospective cohorts, case series, and so on and so forth, things that would not usually have made it through an editorial board, really. And now we have lots more data. It's probably time to raise that bar back up a little bit, to critically appraise things and to look very hard at the information that we've got in front of us. So what more do we know about the prevalence of VTE and COVID-19? Beverley talked very eloquently about the pathophysiology of the disease, and I'm going to focus a little bit more on the evidence that we have and perhaps how we can use it to provide patient care. So this is one of many systematic reviews that have been published since the start of the year, and this one's by Porphyra et al. In Thrombosis Research. Published in May, and this is a systematic review and a pooled analysis really of over 30 studies looking at the prevalence of VTE in COVID-19 patients. I'm sure you remember, if you cast your mind back to our first webinar, that we were talking about VTE rates of 50% in these patients, especially in the critically ill. And actually the systematic review data doesn't really mirror those early estimates. This paper reports an average rate of, I think, about 26% for VTE prevalence in a cohort of 3,500. And actually, if we take out the cases where they use screening ultrasound methodology, then we're left with diagnostic workup for VTE and a prevalence of only 17%, as you can see here, with wide confidence intervals. But that's a very different number to what we first thought the prevalence would be, even in groups where there's predominantly critical care admissions and severely ill patients. Now, following that systematic review, this is another one by Knopp et al. Published in Research and Practice of Thrombosis and Hemostasis last month. And this systematic review on the same topic included 66 studies and over 25,000 patients. So we've doubled our number of studies in 5 months, and we've more than 7 times the amount of patients in 2 systematic reviews. So that just goes to show the challenges that we're facing, doesn't it, in terms of the speed and the scale of the evidence that's in front of us and how we interpret that. Now, the authors here again cleave off studies that use screening methodology to detect VTE and report a baseline prevalence rate in COVID-19 of VTE of 9.5%. So now we're down to less than 10%. And what's fascinating about this is 2 things really. One, when you include the screening studies, then your VTE prevalence it quadruples, so it's up to 40%. And we said that last time in the webinar and discussed it at length, I think. If you look for VTE in patients with acute respiratory distress syndrome and those who are severely ill on critical care, then you will find it. I don't think there's any doubt about that. But of course, what we're really interested in is clinically relevant thrombosis and thrombosis that's treatable through our usual pathways. The other thing that's interesting about this paper is that if you look over time here, you can see there's a trend towards decreasing incidence from February up to May over here. And that's fascinating, isn't it? Because I'm not entirely sure we can explain that. So is that our understanding of the disease? Is that better treatment options coming to fruition? Is that publication bias because everyone was very interested initially and now perhaps the larger estimates that you see up here aren't getting as widely accepted in journals? I wondered if it might be due to something like dexamethasone as an evidence-based intervention, but that's what this star represents over here, because the press release about dexamethasone's importance for the role of COVID-19 in the critically ill wasn't published until July, and that's prior to, of course, the actual publication itself. So I'm not entirely sure that you can account this decreasing trend purely to new evidence-based interventions. We maybe need to think a bit harder about why this is happening and how it affects the care we provide. So we know a little bit more about prevalence, but what do we know about the anatomy of the disease itself? You know, where are these VTEs? If you take systematic review data, then any VTE is an event, isn't it? All VTEs are equal, but we know as clinicians that some VTEs are more equal than others. There's a big difference between a saddle pulmonary embolism in the context of deep vein thrombosis and a CTPA report that says there might possibly be a small subsegmental pulmonary embolism down in the right lower lobe. So we have to think about the anatomy of this disease, and we do have some data on that. Beverley already talked about her cohort from Guy's of 66 critically ill patients, where the reference is down there at the bottom right, and they report a PE burden that's accountable for subsegmental or segmental embolism, or in situ immunothrombosis, if you like, of about 40% of their patients, so a high proportion. Different cohorts have reported very high proportions as well to support this theory. So Middeldorp et al. From the Netherlands, that's 196 patients hospitalized with COVID-19, and over 90% of their PE cases were isolated segmental or subsegmental PE. White et al. Repeated this, more than 50% of their patients, their pulmonary thrombotic burden was subsegmental or segmental. And we can all look at this data locally, can't we? This is unpublished data from our cohort in Salford, but we've just finished collecting and writing up a 90-day follow-up for 496 patients with confirmed COVID-19 by PCR testing. And this is the relative proportion of our VTE burden. You will see here over 60% of it is subsegmental and segmental PE, and relatively low rates of DVT for us in our group. And this represents an overall VTE event rate in our cohort of around 4%, with an equal thrombotic event rate that would comprise arterial thrombosis like NSTEMIs, strokes, mesenteric ischemia, that kind of thing. So we're not entirely sure what the anatomical burden is of this disease, but we are getting more information about it, and what we're certainly finding is a high proportional load of subsegmental PE, which may well represent immunothrombosis, as Beverley was pointing out before. This data is being presented at the Royal College of Emergency Medicine tomorrow, and after that we will submit for publication. So if that's what we know about the prevalence and the anatomy of disease, what do we know about prophylactic options and strategies for treatment? So what do we know about thromboprophylaxis in general? Well, we know that it works really, and I think we probably need to move away from this discussion about how relevant thromboprophylaxis is, full stop. We saw in some of the earlier papers coming through that large proportions of patients weren't being prescribed any kind of thromboprophylaxis with this condition. And that, I suppose, raises concerns about the manner in which that data is reported and whether it's generalisable to our care in the UK. I put the reference down here for Ms. Metti et al. From Thrombosis and Hemostasis in 2000, and that's a systematic review and meta-analysis of thromboprophylaxis for hospitalised, medically ill patients who are expected to be in hospital for more than 3 days. And they demonstrated 20 years ago that thromboprophylaxis at standard dose will halve the risk of subsequent VTE. So we've been doing this for a while, and we have seen subsequent publications like that from King's. This is Laura Roberts et al. Publishing data on the actual impact of routine risk assessment and pharmacological thromboprophylaxis on crude mortality attributable to VTE in an NHS UK system, and a risk reduction of 10% over that time period. So we know thromboprophylaxis works, and I don't think we need to ask ourselves the question of whether it works in COVID-19. But do we need to use more of it? That's perhaps a more pressing question, isn't it? And Beverley alluded to that in some of her final slides. So do we need to be thinking about intermediate dose prophylaxis for some of our sicker patients, or maybe for everyone? And we saw some case series published to that effect in the early stages of the pandemic. And we saw some protocols published and made widely available on the internet. And what do we know about this so far? Well, we don't know a huge amount really. And again, we're seeing retrospective observational cohort studies that are conducted with significant confounding and real risk of selection bias that are being published that, you know, try to draw conclusions from this practice, which we really can't do. We've got papers like Mattioli et al. This is a retrospective cohort of 100 patients, and the headline from this study is that intermediate dose may well be safe because it was relatively safe in that cohort, and they had a low VTE prevalence within 100 patients receiving intermediate dose thromboprophylaxis. I think only 1 PE in the whole cohort itself. But when you look at a different cohort, such as that reported by Bompard, they have a 50% prevalence of pulmonary embolism across 2 French intensive care units when all patients were receiving intermediate dose thromboprophylaxis. So we don't really know if intermediate dosing works, and we don't know whether it's efficacious, and we don't know that it's clinically effective, and we need more data. And is intermediate dosing really any different to weight-adjusted dosing? I'm not sure that it is, and I look forward to a discussion on this as we convene as the panel. This is a snapshot of our local prescribing guidance, which has been reviewed by the Thrombosis Committee a couple of times over the last 2 years. And we have escalated our dosing strategy significantly for the higher weight bands as the SPC has changed to support higher rates of dosing and 50 units per kilogram daily. And then there are consensus guidance documents available from the UK Clinical Pharmacy Association that talk about escalated weight-based dosing. If you were to use standard dosing of 4,500 units prophylaxis in your hospital, then of course 9,000 units would be an intermediate dose if you weren't using weight adjusted. So are these one and the same, or are they different? Certainly some of the systematic review and pooled analysis data that's coming through for peer review that's as yet unpublished is lumping these strategies together. And so we need to really understand what people mean when they're talking about intermediate dosing strategies in the literature. Do we need even more of it than intermediate dose? So there have been publications on therapeutic dose anticoagulation outside of suspected or confirmed venous thromboembolic disease, purely really to try and prevent deterioration in these patients. And what do we know about this so far? Well, we've seen data from Mount Sinai in America, published in the Journal of the American College of Cardiology. And these authors report no difference in mortality between those patients receiving therapeutic dose anticoagulation and those receiving prophylactic or lower dose. But they do report higher rates of bleeding, as you would expect, I suppose, from using higher doses, or as you would construe a scientific rationale. We see other studies such as Litros, and last week there was a Cochrane systematic review published only 10 days ago. So again, that just shows how on the ball we need to be if we want to distill all of this information. And that review draws a fairly clear conclusion that the evidence base doesn't offer any clear information about the clinical effectiveness of treatment dose anticoagulation in COVID-19, and that further trials are needed. Some bleeding estimate rates are provided, and we'll come on to that. But I suppose the point I wanted to make with this slide is that we really don't know that these therapies are effective. You know, we're assuming that they might help, but we have no real clinical proof of that yet. And so we have to weigh that in the balance when we're considering the harm that they might cause. So if we move on to bleeding from there, what more do we know about bleeding? Well, you know, I thought I'd start with some baseline information because, of course, we do have standardized definitions for bleeding that we tend to adhere to when we're all conducting clinical studies. And this is one such estimate from a randomized controlled trial of over 6,500 patients conducted in 2011. This is the ADOPT study looking at apixaban versus enoxaparin for thromboprophylaxis in hospitalized medically ill patients. And so we have composite estimates of clinically relevant non-major bleeding and major bleeding within this cohort. And if you look at this data, major bleeding is only really prevalent in between 0.2 to 0.5% of these patients. Now, although this trial has exclusion criteria, most of those criteria are mirrored in the Department of Health VTE risk assessment tool for bleeding risk. So we can use this data to estimate what we think the major bleeding risk should be in this population, and to think about what it actually is in the reported observational cohort data. And what do we see when we look at bleeding in COVID-19? Well, it's high, and it's perhaps higher than we might expect. So this is data from Al-Samkari, published in Blood relatively recently within the last few months. And there are some nice comparisons here about clotting rates in a cohort of 400 patients, I think, both in those who are critically ill and those patients who are hospitalized but don't make it to intensive care. And if we look at bleeding in particular here, then we see the major bleeding rate is 2.3%. So 4 times the highest estimate in the ADOPT trial, which is interesting, isn't it? Now, this is, again, an observational cohort study, so this data has limitations and confounding that we need to be aware of. But it does make it clear that there are risks, real risks, to escalation of standard dose thromboprophylaxis, and that we need to be mindful of those, and we need to counsel our patients when we're talking about unproven therapies. Another thing I just draw your attention to briefly here is different risk predictors. So can we think perhaps about how we predict risk? And you can see that D-dimer, as Beverley was alluding to, is a predictor of general unwellness in COVID-19. You can see it perhaps alludes to a higher risk of thrombosis, but it also alludes to a higher risk of bleeding. So it certainly doesn't help with VTE diagnosis. When we look at different cohort studies that are using either therapeutic dose heparin or just slightly subtherapeutic dose but higher than intermediate dose, the differences in major bleeding are even higher. So the hazard ratio between these two subsets is about 4, so 4 times the rate of major bleeding in those patients receiving therapeutic anticoagulation in this study. And these patients in the subtherapeutic arm receiving 1 milligram per kilogram of low molecular weight heparin twice daily. So high doses and reasonable rates of bleeding that we need to be aware of. So what do we know about risk prediction in COVID-19? And can we use this to help us decide who might get higher doses of thromboprophylaxis or who might be at higher risk of bleeding in COVID-19? Well, we do know a little more about risk prediction, but we don't seem to know a great deal about how to predict the particular risk of VTE or the particular risk of bleeding. This is data from Wright et al. Published in the BMJ using the ISARIC consortium, so an international consortium of respiratory illness, an observational cohort study again, but this is a decision tool published in the BMJ that was derived in over 30,000 patients, so a huge data set and a very scientifically well conducted study. And D-dimer doesn't make it into this model, unfortunately, because it doesn't have the discrimination or the association with mortality that other characteristics do. Interestingly enough, CRP, as an acute phase protein, does make it into this model. And you can see here how the score does correlate very highly with the probability of death. But this is a score that's based not really on VTE risk or D-dimer or anything that we would have thought of in the initial stages of the pandemic, but it's mapped out really based on physiological criteria, on age, and on CRP on its own as an individual biological marker. So that perhaps gives us some insight into how we view biological thrombosis and how it influences our risk prediction. We're still going with D-dimer though, and Dujardin et al. Published, I think a couple of weeks ago, again in Thrombosis Research, a retrospective cohort study of 127 patients looking to derive a univariate analysis followed by multivariate analysis to try and determine which biological variables best predict VTE risk. And CRP again in their cohort was better than D-dimer. It outperformed it in terms of area under the curve. So we don't know much about risk prediction, and we don't know how it affects our decisions to use thromboprophylaxis, and we don't know how that translates to improvements in patient care. But what do we know about the treatment of the disease itself? Well, we know a lot more about that, don't we? Because we've seen big trials published and we've seen convincing evidence. We know that dexamethasone will save lives if it's given to hospitalized patients who require oxygen, and that data is compelling. We probably know that hydroxychloroquine and ritonavir and lopinavir don't work, despite what a certain American president would have us believe, because we've got good randomized controlled data on those 2 agents that show no evidence of clinical benefit. And we've got other therapies that are still being evaluated, such as convalescent plasma and tocilizumab as immunomodulatory therapies. And that kind of information will continue to filter through. We also know more about how to provide critical care to these patients in terms of early use of prone positioning, awake prone positioning, and different types of bespoke intensive care that may help us increase survival. Does any of that correlate to a lowering of the risk of thrombosis? Well, we're starting to see some data come through on biological markers of thrombosis and how they're affected via some of these immunomodulatory agents. And this is an interesting study at the bottom of only 6 patients who received tocilizumab as an IL-6 antagonist. But if you look at that, standard markers of immunothrombosis do seem to plummet on the receipt of this immunomodulatory therapy. So this kind of cements this hypothesis that maybe it's the immune reaction that we should be targeting clinically, rather than escalating the anticoagulation doses in order to try and break down a clot. If our problem with VTE prevalence in COVID-19 is about immunothrombosis and inflammation and thrombosis in situ, then maybe anticoagulation is not the answer, and maybe it's immunomodulators that will help our patients. And these kind of studies testify to that and are a very interesting read. What's everyone doing? Well, we know a little bit more about that as well, don't we? So this is interesting data from Rachel Rosowski in Boston, an international survey of over 515 clinicians across, I think, more than 40 countries. They were asked specifically who is using escalated doses of thromboprophylaxis, to which over a quarter replied that they were not under any circumstances. If people replied that they were using escalated doses of thromboprophylaxis, they were asked why, and here is a litany of reasons which you could just pluck out of any review paper on the subject. So we obviously are all doing very different things. Some people are using personal characteristics, some people are using biological markers of thrombosis, some people are just using hospital disposition. Where do you end up in terms of your bed, and does that determine how much thromboprophylaxis you get? And of course, this can't all be right, can it? This variation in practice is what we would call equipoise, I think, and what should lead us on to get further research and to concentrate our efforts where they are needed. And those efforts are being concentrated, aren't they? There are a number of studies just demonstrated here that are looking at thromboprophylaxis in the community, that are looking at intermediate versus treatment dose, that are looking at standard versus treatment dose, a couple in the UK, a couple in North America, and several in Europe. And if you look at the Cochrane review, they would suggest there's over 22 trials registered on various platforms that aim to recruit over 15,000 patients in the next 2 years that would help give us more answers to this question. And this is desperately what we need, isn't it? We need randomized controlled trial data that will help us determine which of our known interventions are safe, whether they are safe in the context of what we know about other immunomodulatory therapies, and which provide the best overall clinical benefit for our patients. And what should we do until then? Well, I think we should continue to be diligent about risk assessment and thromboprophylaxis prescribing in general. I think we should strongly consider weight-based algorithms, given the fact that, as Beverley alluded to in her previous talk, we know that increased BMI is prevalent across those with severe COVID-19 illness, and we know that these patients might be underdosed using standard algorithms. We should think about recruiting patients to trials still, because we have ongoing trials in the UK, such as REMAP-CAP, that can engage patients and give them access to research opportunity. And that's what patients want, and that's what clinicians want, and so we should work towards it together. And we should probably think about primum non nocere a little more than we did in the early stages of the pandemic, because we have evidence about bleeding risk now, and we know that our purported interventions are not without harm. And we know that do no harm is one of our duties as clinicians. And we should perhaps think hard about that as we move forwards and ask for more data on efficacy of these novel dosing strategies before we roll them out wide. A final slide, which is really, I suppose, just a plea to the novel concept of evidence-based agility. And this is the idea that as the literature changes so quickly and at such scale, we need to redefine the clarity around evidence-based medicine. We would usually wait for comprehensive systematic review and network meta-analysis data before we change practice. But as the evidence is moving so fast, we do perhaps need to move with it, but we need to be diligent on our critical appraisal, and we keep needing to revisit those decisions, don't we? It takes an order of magnitude higher to perhaps reverse a decision than it does to make it in the first place, and that's a well-established internet truth. And if we have made decisions to escalate dosing strategies, or if we have made decisions to change practice, then we need to consistently revisit those, don't we, in the face of changing literature, to ask ourselves, are we still right about this? And is this still right now that everyone's getting dexamethasone? And is this still right in the era of decreasing prevalence? And we need to keep asking ourselves what's best for our patients, and we need to keep asking ourselves how we can do better. I will stop there, and I look forward to a panel dialogue. But thanks for the platform, and I'll be interested to hear your thoughts on everything I've said. Thanks very much, Susie.
Dan, thank you very much. That was a lovely update on the evidence that has emerged in the last few months on COVID and thrombosis. We've got about 10 minutes for panel discussion. So I'm going to take you both to some of the burning questions, which is really, what are you both doing now for thromboprophylaxis for inpatients and following discharge? And has it changed since the start of the pandemic? Dan, do you want to go first?
Yeah, so I can be quick on that. The only thing we have done about prophylaxis for hospitalised medical patients is we have looked in more detail at our weight-adjusted bands, and we have slightly increased the dosing. We did use weight-adjusted pharmacological thromboprophylaxis, but it was drawn up kind of 5 years ago as an expert consensus, and we reviewed the UK CPA dialogue, the Q&A sessions, and we reviewed the updated SPC for our preferred brand of low molecular weight heparin, and we made some slight revisions to that. We've never used intermediate dose, if you would say that's different to weight adjusted, and we've never used empirical therapeutic anticoagulation outside of suspected or confirmed VTE. In terms of community prescribing, we have not been giving any more other than our standard consideration of 7 days course in keeping with NICE guidance, and that is still a risk assessment and decision making based on the medical consultant who's making the discharge. But with the advent of COVID community hubs, as Beverley alluded to at the end of her talk, we are perhaps going to be a bit more aggressive about community prescribing, and we're in a dialogue about that at the moment.
Great, thank you, Dan. And how about you, Beverley?
So at the start of the pandemic, the ward patients were risk assessed according to the NICE guidance, and not all of them fulfilled the criteria for receiving thromboprophylaxis. We used weight adjusted thromboprophylaxis, and we asked that every single COVID patient got weight adjusted thromboprophylaxis. And then in critical care, they were very anxious. There was huge problems with hemodialysis lines clogging, all sorts of issues. So we agreed that we would go for an intermediate dose of thromboprophylaxis. That was probably the end of April, and we've stayed there ever since. I mean, I'm very aware what's happening in London. There are lots of different regimes. Some people are even using full dose, and actually we were just writing some London-based guidance to go out in the next few days, asking to use intermediate dose in the patients in critical care. And the other thing is the big plea, please, 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 if you've got patients you're not sure what to do, put them into remap cap anticoagulation arm, please, because we need the answers to these questions, and they're not going to go away. And I think comparing full dose low molecular weight heparin with your standard of care, whether it's just using standard thromboprophylaxis or intermediate dose, is a great question. And we're going to get the answers out, I think, pretty quickly, because the endpoints of remap cap, which is a 30-day outcome, is the same as the ATTACK study, which is going on in US and Canada, and they've already enrolled 500 patients, and we're going to pull all the data together so that we can get an answer quickly. So it's really worthwhile doing this. Thank you.
Yeah, no, I agree, and it will be crucial to have that randomized control trial evidence, because having had that initial fear of such high thrombotic rates and a push to increase anticoagulation in case it's of benefit, I think what has emerged in the last few months is partly the thrombosis risk is probably lower than those earlier reports, and partly there is more bleeding risk that has been reported in the last couple of months, and so that the balance is very unclear. So, and how about extended thromboprophylaxis on discharge? Beverley, can you just chat us through a bit of the evidence there that has emerged?
Okay. Dan really covered that, because it's the King's data, which looked at 3,000 patients last year, medical patients, and compared them with the COVID patients and looked at the rates of VTE in the 90 days. I think it was 60 days they went for, I can't quite remember, post-discharge, and they were very similar. There was no difference. And of course, we don't normally give medical patients thromboprophylaxis. For me, I think that the COVID patients are having quite long lengths of stay. So our critical care patients are doing 23 days, the ward patients are doing about 10. So they are already getting extended thromboprophylaxis, you could argue. What do we do? Our guidance say, if you think a patient is high risk, do prescribe extended thromboprophylaxis and either use low molecular weight heparin or low dose rivaroxaban.
Great, thank you. And Dan, the other key area I just want to cover quickly is we started talking about how care was potentially changing. Maybe more patients will be managed in the community through different mechanisms. And Beverley talked about what they're currently doing at Guy's and Tommy's. Do you want to just tell us a little bit about how your setup is changing?
Yeah, so I suspect most regions will have a slightly different terminology for it, but we'll be doing the same thing. And I think the impetus is to try and keep patients out of hospital, firstly to reduce the nosocomial spread within, but secondly to manage the resource that we have. You know, everyone is nervous about a second wave or a continuing onslaught, depending on how you want to term it. And of course, the more our hospital beds fill up, the more everything else stops, such as cancer surgery and elective surgery and emergencies. So we need to be conscious of all these things. And the answer to that in emergency and acute medicine has usually been either same-day emergency care, where we just increase our access to diagnostics so that we can tell people exactly what's wrong and institute definitive management plan at the front door, rather than having a 3-day hospital stay while they're waiting for tests. Or it's about ambulatory care, and you know, we're doing ambulatory care for pulmonary embolism and have been doing for many years. We're doing ambulatory care for deep vein thrombosis, for cellulitis, for lots of things. So I think people are naturally reaching for that. What does that mean? It means, I suppose, an enhanced version of ambulatory care, whereby we perhaps use additional resource. So there's been lots of talk of portable saturation monitoring, so that you can manage it. You can monitor hypoxemia in the community, and you can escalate care quickly. And that's very different, I suppose, to telling people that they're low risk COVID and they need to go home and go to bed and only come home if they get a lot sicker, because we saw within the first wave that people were waiting too long, unfortunately, and would present very ill for a variety of reasons. And so some form of observation and ongoing medical review needs to happen. But yes, at Salford, we are kind of coalescing GP and acute medical services to provide a hub like that, so we can get early diagnoses. We can do biological workup to try and risk stratify people using things like the 4C calculator that I mentioned from the BMJ. And then low-risk patients will be managed in the community with ambulatory saturation monitoring, with daily telephone calls to triage those back to hospital who seem to be getting worse, and for home visits in the community as needed. I do worry about thromboprophylaxis in this group, because we haven't been historically great at risk assessment for those on ambulatory pathways. And if we take a proportion of patients who would usually have been managed in a hospital and we decide to keep them all in the community, can we be assured that clinicians managing those pathways will provide the same degree of rigor and governance to thromboprophylaxis? You know, I think we're trying to have those discussions. We're trying to raise it. We're trying to make it clear to everyone that we think risk assessment should be an actual vital part of this pathway. But those discussions are ongoing, and I think how we capture those metrics will be difficult, because we have a very reliable system for risk assessment reporting in hospital, and we will need to extend that to the community to provide some assurance around it.
Great, thank you. And very quickly, just interesting, looking at the questions that people are submitting, there's a lot around the type of anticoagulant that we're using and how it's monitored. So I suppose, just for ease, what I would say is I think that, and Beverley and Dan, please butt in if you disagree, but I think for someone with an acute VTE, you can use either a DOAC or a low molecular weight heparin. Obviously, DOAC is easier for an ambulatory pathway, and you just need to check the renal function and liver function is otherwise okay, and that there aren't any interacting medicines, including antiretrovirals. I would try hard not to use unfractionated heparin because I think it's so difficult to monitor. And if you're using a DOAC or a low molecular weight heparin in general, I wouldn't use any kind of monitoring. Would either of you say anything particularly different?
I think the only thing is if you have to use unfractionated heparin, which happens occasionally, to use anti-10A to monitor it, not to use the APTT, because the APTT is affected by the very high levels of factor VIII and fibrinogen, and you get better monitoring with anti-10A. Hopefully, each hospital now has a more reactive anti-10A assay available to them.
Yeah, that's a very good point, Beverley. And our final question before I close the meeting, just in the discussions that we had preparing this webinar, we had thought that it might be helpful just to say something briefly about pregnancy or people in the community with inherited thrombophilia. Do you want to just say a few words, Beverley?
I'll do the inherited thrombophilia because it's a question we had from the patients this morning, and I get emailed about it. And I did a Reddit, and that was the common question from people asking. And Facebook, everywhere. GPs, what do we do about people who've got thrombophilia? And really the evidence is that their risk of clots, if they get COVID, doesn't appear to be greatly increased. Now, I think that's probably because the high-risk ones are already on anticoagulation. And the other thing is that they tend to be younger patients, and their risk of getting COVID pneumonia is quite small anyway. So I have lots of patients with antiphospholipid syndrome and antithrombin deficiency, and I ask them to tell me when they get COVID. And some are on anticoagulation and some aren't. And I haven't had any who've had COVID pneumonia, and that's totally anecdotal, but that's all we've got. So I go around reassuring people, if you've had a previous clot and you get COVID, keep mobile, keep active, don't get dehydrated, and you should be fine during the period where you isolate. If you get COVID pneumonia and you get admitted to hospital, you will automatically get thromboprophylaxis. And if you get severe COVID and you require ventilation, people will be thinking about your thrombotic risk and doing what they think is right for you. So it's the doctors are all really, really aware of this. So I think everyone should be reassured that they'll get the best care in the UK hospitals, because everyone is thinking about thrombosis.
Right, thank you. So it's just after 5 o'clock, so really I should draw the meeting to a close. So especially thank you to Beverley and Dan on really thought-provoking talks and discussion, and to Joe Jerome for organising both this webinar and a whole week of webinars. It's huge amounts of work.
And Andy, who set up our platform.
Yes. And thank you to you all for participating. So I mentioned at the beginning, a recording will be available on the Thrombosis UK website from tomorrow. And thank you to all the sponsors and supporters. For those listening, please do visit the virtual exhibition area where there are stands from professional bodies, as well as third sector device and pharmaceutical companies. Thank you.